Good. Thank you very much. So I'm going to talk about how to translate research into practice and policy. But I know I gave a very big title for this. It just reflect what I have done some work in antimicrobial resistance control. So it's my first-hand experience, but also I try to see how it will link with the implementation science. Uh, I would start with the challenge of the AMR, antimicrobial resistance. We know that AMR causes lots of deaths. So it's approximately about 5 million deaths now associated with AMR. By projection, it will have to be doubled in 2050. Will be one of the largest killers among all the different diseases, and it's also very costly. I think everybody know that antibiotic are widely misused in humans. For example, like people who have the common flu, have sneezing and the fever are more likely to get antibiotics, which actually they do not need because those infections are mostly viral, not bacterial. Well, for people with we call it upper respiratory tract infections, over 90% of the patients get antibiotics in many African and Asian countries. The number could be about like 20 to 40% in Canada, and about say 70 to 80% in China, could be around 100% in Egypt. So that are the countries I have been to and visited for this. And in Pakistan could be around say 80%. So we can see a large overuse of antibiotics. And the overuse is not only for humans, but also for animals. For example, the called promotional feed to feed animals with antibiotics before they have any disease. For farmed animals like cows, chicken, and even the salmon for fish, the farmed fish in the sea. So that causes lots of environmental damage because once we wash these places, these antibiotics will be washed off to rivers, creeks, and then will be picked up by humans. And then eventually that will develop resistance of antibiotics, both within our body, but also in the nature, in the environment, and in the animals. So that will be a huge threat to human health. I wanted to share some unbelievable pictures. You might find it striking. So this picture was taken in Cambodia, in a wet market. So the wet market means that you can go to market, buy anything, vegetables, food, live animals, fish, etc. In that part, you can see there's a basket with different plastic bags. And if you dig more, about the plastic bag, you find that there are different colors or drugs. The drugs for example, for fever, drugs for cough. You can purchase for a day. That pill in a bag is for a day, or you can purchase for several days. So the seller does not know what it is inside. And we took that pack of the pills to the laboratories and found that at least there would be one antibiotic within each of the pack. Uh, and most of the antibiotics are coming from the outdated antibiotics, outdated farms, kind of farmers from Vietnam and China. So you can see that those kind of outdated antibiotics were smuggled across the border to sell in the low and mid, the low income, I would say low income countries. And that is another picture I took in China about 10 years ago. So right now, the antibiotic overuse is not that prevalent, but you can see at that time, you can see that people are very common to receive the IV, the intravenous injection for common cough. So that shows that a child is receiving the IV injection with antibiotics with his grandma and mom, so which is quite striking. So what can we do? Those are the studies reported how to reduce antibiotic overuse in healthcare settings, specifically in primary care. Most of the studies are done in the high-income countries, for example, in UK, Canada, US, Europe. Very little of them have been done in developing countries, but now there are more and more numbers because people think, like since you can see in Cambodia, you can get access to antibiotics anywhere without regulations. And for some other places, for example, in China, you do need a prescription to get antibiotics, but you can easily come across that regulation on the website. Well, in the healthcare facilities, you can see many of the uh, primary care providers are not aware about the inappropriate use of antibiotics. So they need training, and their education is not up to the standard. So those are all the challenges. And there would be peer leader training about training the doctors, operational guidelines, peer reviews, and feedbacks regarding what you did in prescription, could you find a way to improve, and also the patient caregiver education. There are also studies regarding the new diagnostic tools, specifically on the C-reaction protein, which has been widely used like just the point of care diagnostic tools. So those are the different studies regarding the interventions to reduce overuse of antibiotics. And I would not go too much into the details. So in general, we found that there had been some success in mostly in high-income countries, and regarding the peer education, peer review, the largest improvement I think from the studies on the, for example, like antibiotic education, stewardship, feedbacks, but the results are really kind of ranging a lot from very minimum, say like 2 or 3% to about 30%. So 30%, we know that is a very good achievement. But if you see the antibiotic overuse in some areas could be about 80 to 100%. So that effect size is still need to be improved. So that's the reason we started the first antibiotic we call the antimicrobial stewardship program in China. So the first study was looking at how to reduce antibiotic overuse at primary care for the children, so for the pediatric population. So they ran a pragmatic trial, which is guided by implementing science approach. We had reported trial and also the process evaluation on how, what the intervention works for whom at which time, etc. So I'm going to combine them together. We also look at the long-term effect, which finds it is very effective. So that is a place which is on the border between China and Vietnam, with minorities and a low-income area in China. So those are the interventions we put here. So we first developed the clinical guidelines because the national guideline was about 100 pages. We reduced them to about 20 pages based on China national guideline, but also national guideline from the UK. So we see what is the core element for family physicians. And then we provide the training in the local language. And then, very importantly, we also did a prescription review. So at that time, the EMR has been used, but not widely used. So we developed a method that the group of doctors could identify a meeting time. Normally they have the monthly meetings. They occupy like a half an hour for the meeting of reviewing the antibiotics prescriptions for each doctor within the facility. So they could say, okay, who prescribed too much over the average, and then would give some explanations. And then the caregiver education. We educated the caregiver because it could be parents, could be grandparents. So we did the randomized clustered RCT. So here you can see we had a population about 1.5 million in 2 counties, and we randomized the primary care facility, they call it township hospitals, into the intervention and control. And we use a primary outcome as the antibiotic prescription rate, which is for uh, all the prescriptions of upper respiratory tract infection among the children. What is the proportion of those containing the antibiotics? And then we look at other rates regarding the multiple antibiotic prescription rate. Do they use a broad spectrum versus penicillin and the intravenous use of antibiotics? If they do not use antibiotics, do they use other things like antiviral drugs, glucocorticoids, vitamins, and traditional Chinese medicine? How does it affect the cost of the prescription? Etc. So I do not want to go too much detail into uh, the findings because you could look from the papers. But here, that is one paragraph shows short-term and long-term effect. So here you can see those are the 24 months. For the first 3 months, those are the baseline period. That is the intervention arm, that is the control arm. So basically, both of them are had antibiotic prescription rate at around 80%, and then the rate has been reduced a lot in the intervention arm within 6 months. Well, you can say the after 6 months, what we did is that we put up all the efforts, all the people, and the review work. So we let them to do their own reviews to see if all the changes could be sustained in a normal setting. And after a year, we found that the gap was still there, but narrowed a bit. And then we look at what is the change of the antibiotics prescription rate by the different clusters. So you can find very interesting differences. So those are the intervention, the control clusters. Those are the intervention. So you can see the control that most of them kind of goes up and down. So there are some noises. And in the intervention, you can see for these kind of dotted lines means about changes within the 6 months. And these hard lines means changes after 18 months, which means that after this long-term follow-up. So you can see some clusters changed not much for the beginning and also after 18 months. But some cluster changed, reduced a lot of antibiotic use in the beginning, but then extended when they are left to do by themselves. And while you could see some of them changed a lot in the beginning, but then the impact has been reversed after 18 months. So what happened? That lead to our process simulation. So we use that framework called the TDF, Thematic Domains Framework, to look at how to change the behavior. So one of the change is not it's about knowledge skills, but also behavior regulation. For example, the uh, antibiotic review would be a way for doctor to review their own behavior and then make the change. Then we linked with all the strategies, interventions, and then linked with the outcomes. For example, the short-term outcomes have doctors increase their knowledge by the questionnaire survey. And how did they change their antibiotics prescription behavior, etc. So those are uh, designed in our trial from the beginning. And then we did the interviews about the providers, caregivers, and we also try to look at the context. Uh, First, we find that, for example, like training is essential, but training is not the key to make the change because we find that after training, all the doctors have improved their knowledge, but only in the clusters who had done pretty good prescription review had made the change of the antibiotics prescription. So, which are related, for example, leadership. If a leader has not only the position but also more clinical experience, and if a leader clearly set up the targets uh, to reduce antibiotics by 40% within 3 months. So that is bold, but where there was a target and you saw more reductions of antibiotic prescriptions. And the review is really essential because we find that in some areas, in some facilities, they put up some rules about how to regulate antibiotic prescription. For example, they could reduce their pay for the high prescribers, or they put their names on the wall called public posting and shaming. So that did not work. We found that in some clusters which are which provided rewards to the low prescribers seem to be sustainable. Uh, that would not relate to too much of the pay increase, but that will give the clinicians confidence and also their praise to for them to continue. And for the caregivers, we find that the education part is not very effective because they did not have a booking system. So they come here, all come here in the morning at 9 o'clock or 8 o'clock to have an appointment. So they would not be having any time to look at the brochures or the videos they put there for them to watch. What is more important is during the consultation. For example, like we ask during the education, we ask the clinician to speak to the patient caregivers, at least three sentences. Using antibiotic would not do any good for your kid. While it would not using antibiotics will not even reduce the severe level of the illness, while using antibiotics will cause long-term problem. So those short messages seem to be very effective as reflected by the patients. And at the environment or the context level, we find that, for example, if patient was not giving antibiotics, the doctor has to give something else to make a prescription and then to be counted for consultation in the electronic medical record system or in the overall evaluation for the doctor and also for the hospital. So that's the reason we found that prescription for traditional Chinese medicine has been gone up after the antibiotic prescription have been reduced. So we did the health economic evaluation and found that the cost of intervention was very low, only 3 cents per 1% done. And that has been taken up to the whole province, so 55 million population. But we want to see how this message could reach to the wider context to change China's national committee of antibiotic use, their policy. So that's the reason we conducted the second trial in Guangdong. So in that trial, you can see we conducted in an area which is a little bit better than Guangxi, but still the lowest income areas. in Guangdong province. So it combines both urban and rural areas. So we did the same, almost the same. But here I want to say what are the differences. The first is that we targeted all the full population, so not only children, because we want to change the national guidelines and policy. And secondly, we included all the respiratory tract infections normally seen in the primary care facilities. But we excluded pneumonia and TB. At that time, we said COPD, but basically COPD has not been sufficiently diagnosed in China, so we probably have included lots of COPD patients. We included participants between 0 to 75 years old, but by the end of the day, when I was writing the paper, I regretted that we should include even more people because that really does not matter for people over 75 years old. That does not make additional harm for them. And in terms of the training, so those are the training. So we use that the guideline from the previous trial, but we make it more cutting edge based on the new information, but also we put it here very clearly on how to manage fever and the differential diagnosis and the emergent treatment of sepsis and doctor and patient communication. Another important change is that we try to link with the EMR, the township, the called the electronic medical records within the township hospitals. And in each township hospital, we set up a stewardship program, which is we want to make a change at system level with the head of the facility or the person who is in charge of clinical services. So they could have monthly review meetings, and there would be AI algorithm in the apps that could calculate the antibiotic prescription rate on average for the facility, and also calculate the rate on average for each of the doctor. So by the end of the month, they could compare automatically about the rate between individual doctors and the average of the facility. If a doctor has higher prescription rate, and then doctor need to reply in their cell phone about the reasons. But that is not is more kind of lightly done, so preserve the privacy of the doctor's prescription. And then that was found to be more acceptable to doctors. And we also ask each hospital to establish its own performance appraisal methods. So mainly focus providing the extra evaluation points to the low prescribers. So mean that more praise and which was learned from the previous trial. We also kind of revise a little bit about the EMR. So if a doctor has to make an antibiotic prescription, there would be pop-up warnings, but then the doctor can say, okay, yes, I decided to go. It can still go ahead, but there are just extra layers of difficult, extra barriers for doctor. We had the medical education for the patients because it was during the COVID. So we developed a QR code. The patient can screen and then can receive in their own cell phones. So we conducted the prescription review in each of the facility. And we use almost the same outcomes, but we added one patient safety indicator here, which is hospitalization rate for any of the respiratory infections or sepsis in any of the hospitals within that prefecture in 30 days of the index visit. So we try to say if we reduced antibiotic use, does it lead to series of infections for respiratory or sepsis uh, in the area? So we use a linked EMR data could identify any of the hospitalization within that area. So including the small hospitals and the large teaching hospitals. So those are the rates. But again, I think it's easier to talk about in a diagram. So you can see that for this study, we had 12 months as a baseline, and then another 12 months as an intervention period, so which is much longer than the previous trial. At the baseline, you can see both arms, the intervention and the control, they had similar antibiotic prescription rates, which is about 70% to 80%. Well, uh, after the intervention, you can see a sharp reduction, which is which means that the antibiotic use has been reduced more rapidly in this trial compared with the previous trial. And then the differences between them would be about 40%, which is much larger. The effect size is much larger than the previous trial. And then the effect has been maintained quite well after 12 months. We also look at hospitalization rate. So you could see both arms had similar hospitalization rate at the baseline, which is very low, about 1%. Well, after that, you can see the hospitalization rate has been increased to an average about 5% during the trial. That is, but there's no difference between the intervention and control. So that is basically about the COVID control policies, because during the COVID, everybody has fever-like illness, specifically in some periods, they have to be hospitalized for at least 14 days to rule out COVID. So that policy has affected the hospitalization rate significantly for both arms. And we also look at the changes. So you could see the changes, all the dark lines are the changes in the intervention arm by cluster. And all the white bars are the changes for the control cluster. So you can see that the changes in the intervention cluster were not that different compared from the first trial. Well, there's one outlier, which is a dark line from the beginning, only 1% change. But if you put into the line of the changes versus the baseline antimicrobial antibiotic prescription rate, you can see this is a cluster, which means that at the baseline, they had a very low antibiotic prescription rate. Well, we worked further on changing national policies. I think uh, I have to see that this trial was led by Professor Nanshan Zhong. Professor Nanshan Zhong is about 90 years old, and he was a SARS hero. He was also the first doctor to announce that COVID uh, can be transmitted from person to a person in 2020, in January 2020, and then that message have been picked up by the government, and then the Wuhan was locked down, and then the Hubei province locked down. So he was the national top doctor, and he is also the chair for the China Antibiotic Use Committee. So that's the reason he really think we need to find solution to reduce the overuse of antibiotics in the primary care facilities. So this trial results is going to influence the China's national policy in a different ways. For example, we're looking how to revise the prescription guidelines and develop operational stewardship protocol and the guidelines to monitor the use of antibiotics in primary care facilities. So by the end, I want to just come back to the point that we employ the implementation science in those trials, who really matter, which really matters, because first we need to understand the context. The context where we are doing the trial play a very important role because we understand how the primary care organization functions and who are the decision makers and how to reach the patients, etc. And we also list all the different stakeholders and we get them involved, the policymakers, the clinicians, and even the patients from the beginning in our situation analysis and pilot studies. And then we try to design a trial in the real world. So we call it pragmatic trial. So there are lots of other information we could discuss in another workshop regarding how to design pragmatic trial. So basically, we try to include as many uh, uh, as for the participants. For example, we try to reduce our exclusion criteria. We try to think how our trial could be delivered in the real primary care setting, and where we look at what is a strategy and how to test a strategy. We call it also a hybrid implementation science trial. So I also directed the Global Implementation Science Lab established in the university. So we talk about implementing science theories because the TDF and, for example, other things like safer, etc., which has been used in this study, actually has been introduced in a subtle way, and then give the examples and how these methods could improve practice and mitigate the gap between research evidence and policy. Thank you.